um, this afternoon. First of all, thank you all for coming. Hopefully you have a good conference. It's good to see people again in person, in real life, or IRL as my kids like to tell me. Just excited to be here today and talk with you about what I continue to feel is an extremely relevant topic, right? In terms of how do you maximize the time of the nurses that we have out there taking care of our patients. You continue to hear about it in the news, you hear about challenges, you hear about shortages, and we're here today to kind of talk a little bit about those, but we're assuming most of you know about much of that, and we're going to talk more about what we're doing about it and what we have done about it and some of the results that we've received. So that's the context. My name is Mike Detchen. I'm the Chief Operating Officer for Mobile Heartbeat. We're a software company that builds enterprise communication software, and I'll let Dr. Anna Baker-Garber introduce herself.
Good afternoon. It's so nice to see everybody. I am the outgoing Chief Nursing Informatics Officer for HCA Healthcare. I've got 2 more weeks to go before I retire, and then I will become the Chief Clinical Officer for Mobile Heartbeat. And so I'm really excited to talk to you a little bit about what we did with this technology at HCA Healthcare and the benefit it can bring to your organization. So HCA Healthcare, in case you haven't heard about us, has 184 hospitals, and we have 94,000 nurses, and we have about 31 million patient encounters a year. We deliver more babies than are born in Australia every year, so that's my favorite statistic about HCA. And we have the Mobile Heartbeat platform in all 184 hospitals. So I can attest to its scalability and its usability.
Okay, so our agenda, as I talked about, we're going to talk a little bit about the pressure that's on nurses and caregivers these days. We've obviously had the COVID pandemic over the past 2 years. That certainly hasn't made things easier, but this has been building for a while, right? We've been talking about the challenges with staffing and shortages and whatnot for a number of years. We all feel it in the room. I'm assuming that you've all been feeling it. We're going to talk about approaches and solutions, right? And then we'll talk about the results of those solutions. So when you think about it, we know nurses are at the center of the care, right? They're the point person for the patients. They are there to assess care. Most importantly, they're there to coordinate and then deliver the care that is decided upon for that particular patient, right? So essential front lines in terms of patient care. And, I've had a chance to be at a number of different industry events, and the topic of nursing shortage continues to come up left and right. Everyone's talking about traveling nurses, the escalating costs, all those impacts that are coming from that. But what I thought was really interesting is, we've probably seen this in the industry, what would you say, Anna Baker, 5 or 6 years now, the building pressures that are coming on that workforce. But then when you start to see it in the Wall Street Journal, you start to see 60 Minutes doing a segment on the nursing crisis, right? You know that it's mainstream news, right? So now everyday Americans are feeling it. Beds aren't open, available, and the impacts are much more visible to the general public. Anna Baker, you want to talk a little bit about the impacts?
So the nursing shortage can manifest itself in lots of ways. It may cause your facility to close down beds because you don't have enough nurses to take care of them. It probably is not helping your patient experience any. With nurses being taking care of so many sick patients, occasionally quality may suffer. And then the finances of the facility are stretched because now they're paying 2 and 3 times the amount that they would pay for an employed nurse for their contract nurses if they can keep them. And and the components that the Wall Street Journal and 60 Minutes have been focusing on, and every one of your organization's leadership is focusing on, is the burnout and the frustration that your nurses are feeling. And so to Mike's point, nurses have been stretched for a long time, and COVID just really exacerbated it, right? So our nurses get into 22 different technology systems, and nurses just go, they just work around, right? They don't complain, they just keep working, but now COVID has made it so that Even those great coping skills that they have made it very difficult to adapt appropriately. So what can we do to help them? So, you know, at HCA, let's see. Try to find more nurses. Have you tried that? Yeah, you have. Try to change your care models. Oh, maybe we can put in LPNs or more patient care techs. You've probably tried that too. I know, we'll give our nurses a wellness app, and then they can practice their abdominal breathing while they're on break. Let's do that, right? And let's give them some counseling when they're not home, you know, when they're at home, right? And so there's lots of things that are going on to try and both support the nurse at work, but also to support them personally. And you know, one of the things that, if you think about the Maslow's hierarchy of what goes on in the hospital, communications is at the bottom rung. If you can't communicate with other people, you can't get your work done. Everything is frustrating if the communication is kludgy. So if you have to call and wait, if you can't find that person, if you don't know that the message got through, if you can't get a return confirmation, if you have to put them on hold and go talk to somebody else, it just makes everything harder. And so while communications is not going to cure your burnout, it is going to dial down your frustration. And that cumulative frustration adds to that background noise that finally gets up to the point where the nurse says, I can't take it anymore.
So what we've done with HCA, we have a platform called MHCure. And MHCure is our enterprise communication platform that is deployed across all 184 facilities at HCA that Anna Baker referenced earlier. It was a 5-year process to roll that out. Lots of people involved, very excited about what that has done. But it's, you know, it is the mobile platform by which nurses and caregivers all communicate across the facilities there. And the core problem that we solve with MHCure is a simple one, right? How do you find people? How do you simply find people and then engage with them in the right context, right? Hospital setting is running 24/7 by 365. People are coming on and off shifts. You don't know who's on shift today. You don't know who's available. You don't know who's in a specific role. You don't know who's taking care of a patient, right? So you end up having these whiteboards across, you know, unit secretaries that are helping you understand who's taking care of patient 201B, right? You know, what we've done is bring all that to the phone, the pane of glass that sits in front of you as you walk around the hospital facility and take care of your patients, solving that one problem. And, you know, the way we do it is our platform, right? We have, you know, the MHCure platform that allows you to find people in multiple ways and then engage with them. Is a phone call appropriate? Is a text appropriate? Do I need to send, you know, a broadcast across all nurses across the entire hospital? What's the best way that you want to communicate for the situation at hand, right? So we find, we engage, we then, you know, take those capabilities and we integrate it into the clinical systems to allow you to send alerts and alarms, right? Nurse calls, telemetry alarms, you know, what have you. And that triggers the same find and engage process in terms of the alarm comes in, I have to quickly assess the situation, and then I need to say, who do I need to collaborate with? So I go back to those same capabilities to find the right people, and then how do I want to engage? Again, same conversation. So that's the basic framework of what our platform does and does at HCA. And you know, what's critical about it, and we're going to talk about this, is it's not just for nurses, right? It's nurses, physicians, you know, ancillary staff, your EVS, your security, your administration, everybody's on it. There's a huge network effect that comes into play because it's a team sport. Taking care of patients is a team sport led by the nurse, right, at the point of care. So, you know, we have this term, you know, when you solve that find and engage kind of paradigm, right, you take these interactions that happen across the hospital. You know, maybe you have a phone tag experience. Oh, you know, you call the unit secretary, who's taking care of this patient, or how can I find, you know, the therapist, or what have you. That might take 15 minutes. You shrink that to 15 seconds. Okay, that's one interaction. Imagine if you shrunk 15 minutes to 15 seconds across thousands of interactions across that facility that happen every day. You're taking all those interactions and making them easier to find and engage. that leads to real enterprise-wide impact in terms of, shorter length of stay, just faster throughput across the hospital, clinician satisfaction, et cetera. We're going to get into a lot more of the results, but that's the basic premise, right? Solve it at a micro level, do it and repeat it, and that leads to macro level results. Does that make sense? Any questions on that? Okay. So let's get back to it, right? We have the nurse at the center of care. We're going to get into specifically how do we solve some of those challenges.
So the first challenge is finding the right person. And Mobile Heartbeat platform gives you a number of ways to do that. So how do you ever remember who the house supervisor is? You as a staff nurse are not going to know who the house supervisor is. You might have to remember the secret phone number that the house soup always carries, right? It's always 7800, that gets me the house soup. But if you're brand new or you're a traveler, you don't know the secret phone number, right? And so you've got to go ask somebody. So this way, I can, if I'm on staff and I need to talk to the charge nurse or the house supervisor, I can look them up by role. I don't need to know that person's name. I know that person is signed in to what's called that dynamic role. So if I'm running the code team today, I can sign in as that. If I'm the administrator on call, I can sign in as that. If I'm the sepsis coordinator today, I can sign in as that. If I'm the charge nurse, same thing. So you can match yourself to the role in addition to having your own phone number. You can find people based on the care team. So I'm the physician getting ready to do rounding. I don't have to call the unit and say, what nurse is taking care of patient of Mike Detchen? I just can look up Mike Detchen as the patient. Oh, there's the name. Anna Rosas is taking care of the patient today, and I can click on her immediately and text or call her. I can also filter and search by units or roles, those kinds of things. And then I can pull up, I can search in the directory. If I know who I want to call and I just want to find their phone number, I can use it like phone directory and call. And so depending on how I'm thinking about the situation, I can search and find that person quickly based on the thought process that's going on in my head. So it makes it easy to find people, key number one. The other thing that I think is really the secret sauce of Mobile Heartbeat is that it aggregates people. The patient is the center of the model. And so the care team aggregates around the patient. So I can see the nurse and the care tech, and I can see who the charge nurse is and who the physician is and so forth. And again, it makes it easy to know who else I need to be communicating with about this patient's care. And that in turn expedites the collaboration and the planning for the patient. The shift-based roles it's a different metaphor now. It used to be that you carried around a specific phone. So sometimes house supervisors carry, I heard just somebody say the other day, our house supervisor carries 3 phones. One's the I'm about to have a code phone, one's the bed management phone, and one's the anybody who's got a question for me phone, right? Right? So now I've got one way to get a hold of her, and she can sign in as head of the code team if she wants to, right? So, and so everybody's got a phone number that follows them. So no matter, and it doesn't change. So when I pick up a device, all of our devices at HCA are shared devices. I pick up the phone for the day, log in, my phone number finds me. And so I don't have to worry about what it is or get the right phone or any of that sort of stuff, right? And then I can also be part of what's called a broadcast team. So if I want to do a one-to-many communication, I'm the charge nurse, and I want to let everybody on the floor know the Joint Commission is coming to see us next. Put your wows in the closet. I can send them out a broadcast message, and it goes right out, right? If I am the administrator on call and a mass trauma event has just happened, I can send a broadcast message out to the entire hospital. Get ready, this is a real life story, 108 gunshot victims coming to our hospital. Big car wreck happens out on the freeway. You know you're going to get a half a dozen of those victims. You can activate the trauma team, right? So you can use that broadcast message to quickly coordinate lots of different kinds of activities. And that's been it's been a great concept for us.
Yeah, one of the neat things about the way we do these shift-based roles is, you likely have some telephony workflows that exist inside your facility. Like you always know, everyone knows the house supervisor is on a number, maybe 8002, right? So even though Anna Baker's, personal number is extension 1234, if she signs in as the house supervisor, which everyone knows is 8002, if you dial 8002 from a desk phone or any phone in the facility, it'll also route to her number. Right? So I can now have multiple numbers that everyone knows. You have these workflows that are ingrained, but we use the software to kind of make that easier. One device, one application to kind of bring all that together for the users.
Great. Another really important benefit of mobile heartbeat is that it integrates directly with your nurse call system. So you don't need a piece of middleware for it. Oh, it makes implementation a little easier. And it doesn't cause any kind of delay. And so the patient in the bed and the nurse or the tech can have a direct conversation. So instead of the call bell ringing where you answer it at the desk and hope somebody's sitting there and they get on the call bell and say, "What do you need, sweetheart?" My pain medicine, I need my pain medicine. Let me find your nurse. Now the call bell rings, the nurse answers the phone. "What can I do for you?" "I need my pain medicine." "Great, I'll go get that. Can I bring you anything else while I'm coming?" "Yes, I'm really cold. Can you bring me a blanket?" "Yes, I'll make sure you get a blanket." Now she goes, gets the pain medicine, gets the care tech to bring a blanket, and you've cut out all those steps in the middle, and you've had a direct connection between the patient and the nurse. And so it makes it easier to communicate, and it's a huge patient satisfier. Another valuable feature is being able to create ringtones that happen for certain events. So I can hear the difference between a telemetry alert and a bed exit alert and a sepsis alert, and so I don't have to pull it out of my pocket to know it. I can hear it and know sort of how urgent it is, right? And so again, that creates kind of a repeatable process. It decreases the cognitive load because it's the same thing and I can remember it without thinking about it. And so that's been very handy. And then we talked a little bit about broadcasts. So if you're a bit, we're all trying to get rid of, and maybe you have already gotten rid of overhead paging, but we've reduced the amount of overhead paging dramatically because we can send these broadcast messages out. So we use mobile heartbeat to call codes of all sorts, right? There's a redundant system, but we don't overhead page hardly anything anymore. And so that makes it quiet. It keeps the alarm factor down. So, if you've got an active shooter event in the hospital, you don't want to call a code silver and get everybody all wound up, right? You can do it silently. And you can tailor these broadcast messages to very small groups or big groups. I'm standing in the med room and I need somebody to help witness me wasting a narcotic. I can send out a broadcast message and they can let me know they're coming. I can do the whole unit, Joint Commission on the way. I can do the whole hospital. We would send out broadcasts to the whole hospital about our changing in how we managed our PPE, for example, at the beginning of COVID, right? And so you can update various kinds of, the status of various kinds of events using the broadcast message. So this is just an example of the PPE thing. I already said that, right? Another thing that's a really valuable, there's a quote that our CIO says that what this really is an innovation platform that happens to do texting, right? You can use mobile heartbeat to launch other kinds of apps in context of the patient. So if you've got Epic Rover, you can launch it to open to the patient's chart. If you have a system that streams live waveforms, you can launch that waveform system and see the patient's EKG or the signals from the ICU. If you've got reference materials, so for example, we put our nursing standards textbook out there, we can launch that. We have A translation app. We've got a positive ID lab collection application. We've got an app that takes a picture of the wound and updates it, loads it into our PACS system, right? So we've got a wide variety of apps that are out on the phone, allowing the nurse to get access to all kinds of things that they need. And one of the ways that you can do that is if you've got another patient-specific app that you want to launch, you can do that through finding that patient in mobile heartbeat and then launching it into the context for that patient.
Yeah, we've had a number of interesting conversations just over the past couple of days about this, because there's a ton of really interesting technologies being showcased this week at HIMSS. And there's a lot of people that says we have trouble getting the nurses to sign in, right? If you have to go and do something that maybe you only do, go over 3 or 4 times a day, it's just an extra step, given how busy everyone is, that you're not going to go and do that. But if that was just a single button inside a platform that you're using on an everyday, every hour, every minute basis, you then enable all these extra capabilities that might exist out there that would really help you. Okay, so we're solving some of that, too many apps, too many sign-ins. It's just too hard to get there.
So this is an example of what it would look like if you launched this happens to be a picture of an app called Airstrip One, which allows you to see the EKG waveform or fetal monitoring waveform, or you can see all the waveforms from the ICU. So for example, you're the hospitalist or the intensivist and you just got a phone call about somebody and you want to open up and see the signals, you can launch that through mobile heartbeat. So this just gives you an idea of how easy that is to do.
Right, what you see there is, in the middle, that's an alert that comes in, right? So the alert comes in and then you have the option to then, do I need to see the waveform? Right. I can see the waveform in real time. I come back, right. I get back into my, okay, what do I need to do? Who else do I need to collaborate with? So all within the same workflow.
Sorry, yeah. So we do this with our telemetry right now. You get an alert on the phone that says your patient's in an arrhythmia. You can, from that alert, launch Airstrip and see what it looks like. Okay. Another really valuable component has been being able to integrate short training videos. And so, for example, at the beginning of COVID, we made little short training videos about how to put on and take off that N95 mask safely. We're getting ready to roll out this wound imaging app. It's really easy to use. We made a little short video of it. We're going to put it out here, and we're going to train the nurses on the phone rather than make them go out to HealthStream. Oh, we all hate that, right? We're going to be doing, we're getting ready to upgrade our EMR. We're going to put out a bunch of training videos for that, and again, it'll be the same kind of thing. So this being able to, you could have a message from your CEO. It's Nurses Week, and the CEO wants to thank the nurses. You could make a little video and put it out there that they could see, right? Send out a broadcast message that says, hey, I've got a video for you. Go watch it. Yes, ma'am. Yeah, no is a short answer, I think.
Well, it depends on the application you're launching to, right?
Yeah, right.
In the mobile heartbeat platform, we wouldn't track that.
Right.
But if you have like a HealthStream that we're launching into, that would then track it.
Yeah. Or Ambify or something like that. Mm-hmm. Okay. Next.
Any other questions as we're going through some of this stuff? Thank you for that, by the way.
Sir. All right. We did not pay him for that plug, but that's coming. All right. Ready? Okay. So I want to talk about the importance again of having a solid communication, seamless communication platform in time of disaster. It seems like our the frequency of both our man-made and natural disasters is increasing, right? While the 108 gunshot victims was enormous, right now it seems a long time ago, right? So there's wildfires, there's hurricanes, there's tornadoes. Did the tornado alert wake you up last night? Woke me up, right? So being able to coordinate the care quickly, knowing who your HIMSS commander is, knowing who your administrator on call is, being able to sign into those roles, everything can just happen. And you can tailor your broadcast messages, your text communications, your phone calls, and your group chats to help coordinate that care, and this really becomes an excellent conduit to do that. So, so it has been very much an enabler of things happening quickly.
Yeah, this particular case study was referencing the shootings that happened at a Jason Aldean concert in Las Vegas a few years back. 80% of those victims went to an HCA facility. They happened to have had mobile heartbeat at the time, and it really helped process that surge and just that scenario.
Oh, benefits for providers. Vikesh, would you like to say all that again for me? Yeah, thank you.
That's great.
Yeah, one of my favorite stories about the provider is there was a guy who would round around and he would send a text message out to the charge nurse. I'm going to be on your unit in 10 minutes. Tell everybody who's got questions for me to meet me there, right? And so rather than so he would just coordinate his visits with the unit ahead of time. I love that story, right? The docs hate getting a page or something that they can't respond to, and then they can't find the right person. So it dials out all that frustration. I will say that at the very beginning of this, another one of my favorite quotes was this ICU doctor who said, and I quote, "Who knew nurses had so many questions," right? And so one of the things that's important when you implement this is realizing that this is a clinical tool, it's not an IT tool. And the customs that apply to us in our social setting are generally not appropriate in a clinical setting. So it really takes clinical leadership to set the tone for the appropriate use and the style with which you use it, and help your physicians understand that putting an order in a text message, not a good idea, and you have to help your nurses say, "Thank you for letting me know, would you go put that in the EMR for me?" So there are rules of engagement, and there's culture issues in every facility. So your leadership, both on the medical and nursing side, need to stand up sort of those expectations about, please don't pester the doctor, and at the same time, please doctor, if the nurse got a legit question, please respond, right? So occasionally it takes a minute to get through that, but once you come up with a culture and a set of expectations that you like, people really appreciate the convenience and the quickness with which this works. Yes, sir.
As an ICU physician, I wanted to thank you for what you just said, because, the whole conference seems to be very nurse-centric. There are very, very huge and surmounted challenges on nursing staff and burnout. But remember the disparity, right? So there's a lot of shortage on the physician side.
It is.
One example is one of the hospitals I take care of at night. We're the only practitioners, right, in the entire hospital.
Right.
And the disparity of 100 to 1 is very real. And the fact that you just talked about streamlining content, not only the ability to reach, I think is also a depth that has to be
Right.
looked into, because you can suffer the death not by a million cuts, but by a million texts.
You can.
Because it really ends up being beep, 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 and the hammer page is a very real PTSD thing.
Yeah.
So I love the fact that you mentioned it, because it's a very pyramidal kind of a scenario where
Right.
all of a sudden you give
Right.
access.
Right.
One phone call, 100 nurses communicating with one physician. Overnight scenarios where a sparse physician.
Yeah. So it's really important to work out the rules of engagement.
And as a critical care physician who just came out of some pretty hard stuff, there is a lot of burn on both sides.
There is. Yeah, so we appreciate the impact that it's had on you guys, and don't mean to leave you out, so, but thank you. Yeah, yeah, right.
You have to start somewhere.
Have to start somewhere, right, right, yeah, yeah. And, you know, and anytime you make a culture shift, there's some jockeying that happens while you're working it out, right? And so, you know, it's like some of the social conventions that we don't think about as saying, hey, what's up? And then you start the conversation. You don't need to do that in a clinical setting. Please, oh, please don't use emojis because they can be misinterpreted, right? You know, and so as we think about when we do handoff conversations and we frame the question, you know, we work on framing the question in a way that is clear in the communication. I think we also have to learn how to tailor the density of the communication to the situation. So sometimes a quick question, a text will do. Sometimes one or two back and forth, okay, but if it starts to be more than that, you probably need to pick up the, you know, do the dialer and call, right? What are you laughing about, Vikesh?
No, so our CHIO, we shared this story yesterday, but there was a conversation between a physician and a nurse. So the physician asked the nurse, can you please help me with this task? The nurse said, absolutely. The physician said, thank you. The nurse replied, no, thank you. The physician said, I appreciate you. And the nurse said, so do I. No, that's 7 text messages.
Right, yeah.
But more than anything, it is the Pavlov reflex of
Yep.
and it's maddening when you
Yep. Right. Yeah, so but you don't want to be having an information dense conversation with text. So if you've got, you know, nuanced questions, please pick up the phone and talk to that person, or say, I know you're the only guy on, when you get a minute, will you come by? I need to talk to you, right? And does it need to be in person? So we don't want the phone to be used inappropriately, and we don't want text to be the reason that something gets missed. At the same time, there's a huge slice of communication where texting expedites things, right? And so, so you, as you're implementing, you work out sort of these rules of engagement, right? We have a hospital in Miami that doesn't text very much. They like to talk to each other. Okay, so they call each other. Like their telephone usage, their phone usage is much higher than their compatriots because that's their culture. They're a face-to-face, talk to each other conversation. But there's other facilities that are very text-oriented, and so you just really have to sort of work it in. But you have to set expectations that will work for your staff, and you have to hold people accountable to it. And your support team, so you've got the people who are taking care of the patient, and then you've got the people who are taking care of the care team. So the network effect here is huge, right? We have known some places that only give mobile heartbeat to the nurses, and they go, yeah, it's okay, right? But nurses need to talk to other nurses sometimes, but really they need to talk to everybody else. They need to talk to transport, they need to talk to case manager, and they need to talk to the food people, and they need to talk to EVS. And sometimes they need to get a hold of security, right? If you don't give all the people in the network the same platform, you don't get the big benefit. So it's well worth the investment. We started out giving, we sort of think about our ratio of phones to beds. It was just sort of the easy way to do the math. And we started out giving out 1.25 phones per bed. Now we give out two phones per bed. And we give it to, we don't give it to every EVS. We give X number to the EVS department. They decide whether they want the individual housekeeper or the supervisor to have it. Same with food and nutrition service. In some of our hospitals, there's a concierge who goes around and talks to patients. That person's got a phone. The person delivering the tray, maybe not, right? So you can think about what your care model is and how you want to adjust the phone delivery or usage. There's also a desktop version, so the unit secretary is in the desktop version all day long. Bed manager in the desktop version all day long, right? So they don't need a phone, but they do need access to the desktop version. And so if you have the support people who are supporting your caregivers on the same platform, you don't have to think twice about, oh, that person's a desk phone call. I gotta, they only sit at their desk and I gotta call them, whereas these people I can text. Again, it decreases that cognitive load, and it creates a culture of everybody communicating in a similar manner, and then that adds to your ability to kind of create a shared experience.
So hopefully you're getting a sense of some of the capabilities that help drive, real impact across the organization. One of the questions we always get when we're talking is like, well, how do you measure that, right? How do you measure that, and can you quantify that and turn that into an ROI statement? So, we've collected some of these statistics from a number of different customers. This is not HCA. We'll talk about some of the HCA results in a second, but just wanted to share some of the things that we've measured and seen, right? So we talked about the reduction of overhead paging. What does that mean? Noise reduction, right? Quieter rooms, better patient satisfaction from that. We've got better communication, allowing pressure injuries to be reduced, right? You're just communicating more regularly about the timing of that event. Same thing with falls prevention. Those are things that can be turned into an economic benefit, right? We understand how that math works in terms of the impacts on reimbursement and whatnot. So, there's ways to do this. Every facility looks at it differently, right? So we have lots of ways to kind of calculate it. We don't know exactly what's relevant to each particular facility, but we've got a lot of the depths of the stats to kind of give us the information to create an economic argument for why these things make sense. Right? When you think, beyond just the nursing impacts, you think about other measurable, outcomes, you start to think, hey, if I do this 15 minutes to 15 seconds things, I can reduce length of stay, right? Huge impact, right? I can, move people through the facility, right? When beds come open, I can fill that bed. When I can, ED to bed placement, discharge order to discharge, right? All those processes just go faster, right? And some of those processes are outcome-based, right? If I can get people through the initial stroke treatment, that has huge impacts on their functionality, right? So there's lots of different ways to get there. These are just some of them. Happy to get into it with any of you as you see interest and would love to learn more. Now, specific to HCA, right? We talked. The platform, I'll let you get into the actual results, but I just want to kind of talk about it. We spent 5 or 6 years rolling this out. You can imagine 184 facilities, you don't turn them on. These are 184 facilities that didn't have mobile phones 6 years ago, right? So, HCA has purchased 130,000 phones across 184 facilities. We've turned them on, trained them up, got the processes, and that's, Anna Baker and her team. I couldn't speak more highly of them. But you see the numbers here in terms of users, phones, communications, and nurse calls. But I'll let you talk about the impacts of those.
Thinking a little bit about how we rolled it out, the first set of hospitals, we were test driving the hardware and test driving the Wi-Fi and test driving the workflows, right? So, it does run on your Wi-Fi system. And so there, for us, there was a certain investment to remediate the Wi-Fi. Oh, guess what? We had a couple of dead spots. I bet you do too, right? So we had to find those dead spots, and we also had to fine-tune the Wi-Fi so it would work on the phone. So as an example, in the early days of the Apple phone, we started out with an iPhone 5. That was seems like a long time ago. The antenna in it was tuned to hold on to the Wi-Fi node for as long as possible. So if you've got 3 Wi-Fi nodes in a row going down the hall, and you're on the first one, it's going to hold on for dear life as you go there. You might get by the second one, and then when you get to the third one, it's dropped the first one, and then it has a hard time finding the third one. So we actually had to turn down the power of our Wi-Fi nodes so the phones would pass gracefully from node to node. It took us a couple of minutes to figure that out. Once we got that done, then from a technological point of view, it became much more stable. And we really saw the power of the communication. And we really observed how the facilities were using it. By the time we got to, our first wave, we did about 10 sites. Our second wave, we did about 15 sites. Our third wave, we did 50. And we gave them workflows that we thought they could work on, and we asked them to focus on workflows that they thought where communications would be of value. So for example, do you have lousy communication during your bed placement process? Where can mobile heartbeat fit into that? Do you have delays in your transporters because the transporter can't find the nurse to find out if the patient's ready? Work on that workflow. Do you have communication issues between the case managers and the nurses? Let us help you with that, right? So we would lay out about a dozen workflows that they could focus on, and they would pick a couple that would be their sort of demonstrate the value ones. This has got to be really workflow based. You can't just hand it to them and expect that they're going to know what to do with it. So part of our implementation plan is to go in, assess how do you communicate about this, that, and 15 other things, and then we help them map those things over into where mobile heartbeat can and cannot be of help, right? And then it's a big day when it comes to phone distribution day. Everybody gets an iPhone. They're waiting in line for the cart to get their phone. And then we stay a day or two to make sure that they're using it well. And that's been a successful strategy for us, right? So we send almost 500 million communication events a year. And that includes our text messaging. It includes the nurse call, broadcast message, and phone calls. So, we here's a sort of a funny story on us. We went into a big hospital in Denver, and we were still there. It was like day 3 into implementation, and we had an inadvertent downtime. And the hospital panicked. What do we do? Do you remember last week? Right? And so it gets ingrained in your workflow just that fast. And so it's very quickly adopted. And it very quickly becomes the thing the nurse turns to. If you think about 180 million nurse calls received, and you think about all the time we dialed out in terms of quickness of response, that's a tremendous amount of care expediting and patient satisfaction. And those are real, intangible but real things that we're proud of. And at the end of the day, this is about making somebody's life easier, right? It makes the nurse's life easier. They can get help without leaving the patient unattended to go find somebody. The patient is happier because the patient can watch your staff coordinating care in real time. So, for example, we sadly had a colleague who was in a pretty bad car wreck, and she was in PT. The nurse texted the PT and said, her name was Lynn. Where's Lynn? I want to bring her pain medicine. PT said, oh, we're down in room whatever. So the nurse came and gave her pain medicine while she was in PT. She asked the nurse, what's my plan for rehab? She texted the doc. The doc texted her right back. All real-time care coordination. And she felt seen and heard, right? So, the patients don't think you're in there looking at Facebook. They think they're working on your behalf. We talked about the physicians. Bed management, has gone from a serial phone call, pick up the phone, put it down, pick up the phone, put it down, pick up the phone, put it down, to having the desktop. I've got 3 or 4 conversations going on. I'm waiting for an answer over here. I'm talking to this person. I'm getting this one started. And so now I'm managing in parallel as opposed to in series. Transporters like it because they sort of lose track. Oh, who am I holding for? Which patient is this? This way, when they're coming to get the patient, A, is the patient ready? B, did you do the MRI assessment? And do I need to bring a stand for oxygen? Right? Get all that done. That's how we decreased our radiology turnaround time. It wasn't that we processed the X-rays faster; it's that we got the patient to the X-ray department faster. Right? And we've talked about the value in a disaster. So at the end of the day, we're not solving burnout, but we are driving out a lot of frustration, and we're creating a platform that creates a shared culture in your organization, and we're creating a platform that you can use to bring other kinds of tools to your clinicians. Other kinds of apps, other kinds of information, other kinds of references. So it unifies your ability for your clinicians to get the information they need, whether it's from another person or whether it's from another application or another part of your internet. So it's been a very valuable experience for us. So with that, we're happy to take additional questions, and we want to know if those things with the green and white icing taste good. That's what I want to know. Okay. Any questions you all have, sir?
So
Gadgets, yep,
per se, the phone.
right.
And phones are going to be one platform, and they're eventually going to be obsolete at some point.
At some point.
Without going into, having everybody wear their VR goggles when it's the patient, which is absolutely ludicrous. Where do you see other things fit, like, watches or other
Yep.
mobile platforms? What happens to me personally is that I'm doing a procedure on a patient on a room ground up, and this thing starts going, and I
Yep.
can't access it, but I look at my phone and I can very quickly
Yep.
access it. And these are hands-free.
Right.
What do you envision in that?
Do you want to talk about that a little bit? You want me
You know,
to?
the hands-free piece?
Well,
just-
or what other gadgets you expect mobile heartbeat to move toward?
Well, I mean, certainly hands-free is a big part of the equation in terms of solving for that. We've got some early stage, options for how to, either through third-party peripherals or, even just, by voice enabling the phone itself, right? You'll be able to access a lot of the same functions. There's also the ability, if you're in procedure, to kind of, forward all your messaging and kind of ensure that you're not getting buzzed, right? Only for the most significant events that you need to respond to.
Yeah, I think it's a really interesting question. I think the phone as a platform is incredibly useful in lots of situations, right? It's very extensible. It doesn't solve all your problems, right? The hands-free problem is a real one, and I would say that there are some areas where pulling the phone out of your pocket doesn't work, and you just named a good one. There are other ones, right? We could put, an earpiece in and talk to the phone, and I don't know whether clinicians would see that as a benefit or a hassle, right? Now, from an IT point of view, now we got, Bluetooth stuff to deal with, right? And we got all those little devices, and they're likely to get stepped on, right? The hands-free badges work, but then everybody can hear your conversation. You don't want that either, and you can't text, right? So, if you're in the OR, okay, everybody can hear your conversation, but if you're in the ED or the patient room, you don't want to be talking about that stuff, right? So, I think that, short of the thing telling you the outcome of the alert, you need to go to room 203 to deal with that patient's arrhythmia, and it telling you in a way that's private. VR glasses aren't it, but is it earpiece? Is it, I don't know about watches for nurses because, like everybody else, they wash their hands 75,000 times a day, and I don't know whether that's a help or a hindrance. Plus, it's a really small amount of real estate, and it takes two hands to text back. You know what I mean? There's not a great, you can do that, but you still have to hit the button, and you got to tell, you know what I mean? You got to send it, and so it's still tying up both your hands.
Thank you very much for thinking out loud
Right.
and sharing with us your thoughts.
Yeah, I think that the phone is here for a while, 2, 3, 5 years. It's become so ingrained in what we do, and they are so powerful that I think it's going to be hard to, and they're so flexible, I think it's going to be hard to displace it, but how the information is accessed and how it's delivered may evolve.
I don't think it's displaced as much as how do you augment it?
Augment,
right?
right, yeah. Right.
There's the 5 or 10% extra that you can do with it.
Right. Right.
There's certainly room
Yeah.
there.
I think there'll be stuff that gets layered over the top of it, but I don't think it's going away for a little bit. Yeah. Yes, ma'am.
So there's something in here about it's not a secure texting platform, but a way to deliver secure texting features. So is it, like, would you still, I saw you had Epic Rover connected to it.
Yep.
Are you using the Epic secure chat through the application? Is that how this
We have some customers that use Epic Secure Chat, but yet still use the other capabilities that complement the Epic platform. Right. So there are some customers that would like the texting in there for a variety of reasons, but there's so many other things that you're doing here.
But it does not send stuff in through Rover to text back and forth. So if you're going to launch Rover, then Rover's up, and you can see the chart, and you can then text from Rover. But does your administrator on call have Rover? Probably not, right? And if you're talking, and I don't know that the physicians have Rover, the nurses have Rover, right? And so, so it's not, it doesn't, you've got it, but it doesn't support the network effect in the same way that this does. So that's the trade-off.
So what my rest team was going to ask is it discoverable?
Yeah, right. So,
Go away?
Well, that's
Yeah,
why
right.
you, that's
Yeah.
why you want this platform,
Yeah,
right?
yeah.
Because you control how long the data exists and when
Right.
you want to archive it and get rid of it.
right.
So it's not discoverable.
So it does not go into the mobile heartbeat chat does not go into the medical record, right? You can save them if you want, and you can make them discoverable if you want, or you can let them go away after 30 days, right? So, but they are not part of the medical record.
So you mentioned it's not integrated with you don't pull data from Epic. How do you figure out what nurses are assigned to a particular unit or a particular room to assign the call beds?
Yeah, so you can either do it in mobile heartbeat or you can do it in the nurse call system, and then the nurse call system will feed it.
And all the CNAs also have mobile heartbeat? Or
Yes, they do.
Oh, that's right.
Yes, they're part of the network. Sir?
Thanks, very nice presentation. Really like the application. I like the feature of the care team and managing and knowing who's on the care team. How do you manage that dynamically? How do you make sure that somebody who just simply touched the patient once a year ago is not on the care team now forever?
Yep.
And likewise,
Yeah.
somebody who might have done something really minor but should be on that care
Yep.
team for at least 1 hour, a day or two, of giving an IV.
Yeah, well, partly because we're not pulling the care team from the medical record in that way. So we're not looking at the problem list and who was the nephrologist and the cardiologist and the oncologist and associating them with the care team. It's not an EMR-like concept, right? So again, so somebody has to either assign themselves or do it through another app that assigns them. So it's not. We're not trolling for indications that you are now or ever were taking care of that patient, right? It's done in real time and it's managed in real time. So the good part about that is it's current. The bad part is somebody's got to do it. Right.
And you can source it from multiple places,
Right.
So,
Right.
Some of our Epic customers use treatment team, right? So we can take the treatment team. You can also get nursing from the nurse call system. We stitch it together in real
Right.
time, provide as comprehensive a view as you have.
All right, I've got to catch a plane, so I'm going to give somebody the honor of the last question. Oh, yes, sir, Ted.
I would love to know if, my wife, my family always says happy life, right? So how did it change the happiness for your clinicians and overall their satisfaction?
Yeah, so that's a great question. If you don't know me by now, you know that I'm a brutally honest person. And one of the things that our CEO asked us to do was go mine through our employee satisfaction surveys for evidence that mobile heartbeat, changed the nurses' lives. And to be clear, it did not, first of all, those questions are asked in a way that it was really hard to mine for that, right? Do you have all the tools you need to do their job, right? We didn't say, do you love mobile heartbeat and did it change your life? So, in the context of those surveys, we didn't find very much evidence other than the occasional comment. If you go on the floor and you ask the nurse, which would you rather give up, your right hand or your phone, they'll pick their right hand. So, and it's such a part of our culture now that they can't imagine doing their job without it. So, and then they go on with their day. So it's not a, gee, this makes me happy experience. It's so incorporated to how they do their job that they don't even think about it anymore. So in that sense, it's highly satisfying because it's totally integrated in what they do. Thank you so much for coming today.
Yeah, thank you.